So our first talk is Dr. Ellis. So he works with me and Graham at the National Aspergillosis Centre, and we're going to hear from him about the ABPA guidelines, because it's quite a confusing topic. And when we've talked about this sort of thing in the support group, it's something that people have been really interested in.
Thank you very much, everyone. It's a real pleasure to be here. I want to just start by thanking Beth and Graham. There's an enormous amount of organisation that goes into these, and it's great that they spent so much time. And big thanks to Beth, who I sent my slides to, and she took one look and thought they needed editing and making a lot more friendly. So thanks for her for putting the effort in. So I'm going to be talking to no, it's absolutely fine, Beth. You've made them much better. I'm going to be talking today about diagnosing ABPA, a very confusing topic, and one that I think, frankly, doctors and specialists are to blame for making so confusing. And in particular, I'm going to be talking about different set of guidelines that exist internationally, which I think causes a lot of the confusion. But hopefully I'll be able to shed some light on this area. So I found this a little bit difficult to pitch it to in the right way. This is a talk I give largely to other consultants and registrars, but to an expert patient group, it's quite difficult to get the right to land it correctly. So please let me know. But I've tried to get a nice mix of sort of science guidelines and interests. So do tell me if I've got it right. So this is when all of us do our consultant exams. There are a number of things that we have to jump through, a number of hoops, and we get a multiple choice question exam. And this is the sort of style of things that we get asked. And I'm not going to sort of ask for someone to put their hand up and tell me, unless anyone wants to mute themselves and tell me the correct answer. But this is, if you have an idea about whether you think A, B, C, or D is right, and I'll just give everyone a moment to read, and then I'll give you the correct answer. So in the interests of time, the correct answer is D. Aspergillus is named after an implement for sprinkling holy water. So Aspergillus oryzae is an essential ingredient for, it's actually Japanese foodstuffs. And anyone who's interested in Japanese cooking or cuisine in general, Aspergillus oryzae is essential for the production of the sort of unane flavor, which is soy sauce, and also in the production of Japanese rice wine, also known as sake. And Aspergillus basically can ferment long chain carbohydrates, which things like yeast, which we use obviously in the fermentation of beer, can't do. The second one, Aspergillus fumigatus, is responsible for almost 2 million tons of citric acid production. That's Aspergillus niger. You see, this is the level of detail that we get asked about. And C, in the video game, this is a pop culture reference. This is the cordyceps fungus, actually, rather than the Aspergillus fungus. And anyone who's interested in David Attenborough, this is well worth a YouTube of, and I think I've got a picture of it in the next slide. But at bottom middle, this exists only in the tropics, and invertebrates, we don't know whether they inhale or ingest the cordyceps fungus, but what we do know is it takes over their soft tissue and basically then bursts through their sort of exoskeleton layer, and produces its spores from the fruit. And there you can see in the bottom middle the cordyceps fungus doing that. Bottom right is an aspergillum, which is the holy water thing used in mostly Catholic churches, I think. So what is Aspergillus? Well, this is an electron microscope picture of the Aspergillus fungus as it grows. And you can see, as you just look through these quite pretty pictures. In B, you've got this picture up here, if you can see my cursor. B, you've got the stalk with the start of a vesicle, which is happening in C. You can see the kind of the head there. And then D, E, and F, you've got the pictures of the conidia, as we call them in their scientific term, or the spores as we know them commonly. And it's these conidia or spores that are released by the Aspergillus fruit that go off, and we inhale hundreds of millions of these spores throughout our lifetime. And that's quite normal. Everyone inhales these. What is abnormal is individuals who develop a reaction to those Aspergillus spores. And you can see here on the left, what is ABPA? It is an immune response to Aspergillus, and it usually happens always happens in the presence of an underlying disease such as asthma, cystic fibrosis, COPD, or bronchiectasis. And this is the bit that I sort of struggle and hope that I've landed right. This is a pictorial representation of what happens within our body that when we breathe in the Aspergillus fungus, and this is produced by one of my colleagues in London, who some of you might be looked after, called Anand Shah, who's a really lovely man, and he's published this picture, which I think is very, very helpful. And I hope everyone can see my cursor. At the top you have the Aspergillus fungus landing in our airways, and basically our white blood cells, so this marked APC, picks up little proteins that exist on the surface of the fungus and then show them up to our other white cells that then begin proliferating and communicating with each other. And you can see that this excess communication and proliferation of the white blood cells lead to a really horrible big immune reaction. And there's some things here which some of you will have seen in your blood tests. So a very high IgE level and a very high eosinophil count, or it often appears in your blood test as EOS. And basically the combination of these IgEs and eosinophils lead to our airways getting narrow and lead to a lot of mucus being produced. And in red here, you can see the various targets we use to target these white blood cells, or the communication between them that often I'm trying to get more and more of our patients onto them. And so some of you will know drugs like dupilumab or omalizumab, benralizumab, mepolizumab. And then of course there's the strategy of actually getting rid of the Aspergillus fungus itself. Azoles are up here. Now let's move on. I think that's too much of that slide can get to everyone's head, but that's generally speaking what's going on inside our body and in our airways. And then I've labeled the slide, why is there confusion over the diagnostic criteria? Well, this is why. There's actually, as far as I can tell, about 6 different guidelines in circulation for the diagnosis of ABPA. And with that many guidelines, it's always going to result in confusion, not just for patients, but for healthcare professionals as well. And I'll highlight one of these. So this is the Isham consensus. This is quite old now, actually. This has changed, and I'll talk through some of the changes. But Isham is the International Society of Human and Animal Mycology. And these are the 2 guidelines I wanted to talk a little bit about today. So on the left are these Isham guidelines, and these have been published in the European Respiratory Journal about a year ago now, and you'll be able to see the names of the people involved in that, and see that the Manchester group as well as other people internationally have been involved in the writing of those guidelines. On the right hand side is the British Thoracic Society guidelines, which haven't been published yet. They're out for consultation, So members of the public are having a look at these guidelines now, and we're hoping they're going to be released in about summer. But they do have differences. And again, if you look at the author group, you'll be able to see many people who are, I think some of you will be treated by, but also other members of the Manchester group. So perhaps we're not making these easy for ourselves by contributing to two sets of different guidelines. But these were the two things that I wanted to compare, and there are some really important differences between the two that I think reflect international thoughts and differences. So these are the diagnostic criteria. Now this is a busy slide, but I often keep these slides a little bit busy because sometimes people like to take photos of them and things and refer back to them later. On the left-hand side, as you look at the screen, are the ISHAM guidelines, and on the right-hand side are the British Thoracic Society guidelines. You'll note that in terms of the essential components for the diagnosis, a serum total IgE of 500 or above has been adopted by both the BTS and ISHAM. And that's a difference that existed about 12 months or 18 months ago, where the upper limit of an accepted guidelines was 1,000. The point that I always make, and hasn't really been addressed by either set of the guidelines, is that relatively speaking, the Aspergillus total IgE is very low. So we talk about a total IgE of over 500. Well, the Aspergillus IgE only needs to be above 0.35 to make the guidelines. So you can often see that patients will have a massive amount of other things that they're reacting to that are putting their IgE up. And often, even though we say someone has ABPA, we'll often say, actually, there's no room for azoles in this treatment because the patient's being set off by other proteins and things in our atmosphere. The rest of the guidelines are fairly similar, actually, and that's good that we're keeping things similar between the two things. You'll notice that sort of at the top of the ISHAM guidelines, it talks about patients need to have a predisposing condition such as asthma, cystic fibrosis, or COPD or bronchiectasis. And in the BTS, the British Thoracic Society guidelines, it's essential that patients have an underlying obstructive airways disease. And what we mean by that is not that there is a physical obstruction within the patient's airways, but that the airways are more narrow than they should be. And that's what we mean by the obstruction. There are other elements that are part of the guidelines. So you'll see a raised eosinophil count, a raised total IgG, as well as things like radiology. So those make up other parts of the guidelines that you can essentially substitute in if needs be. Treatment-wise, now this is important for everyone, that there's a real importance about differentiating treatment for acute flares of ABPA, many of which audience members will have suffered, and then the maintenance therapy. So what maintains us in good health and stops us from developing these acute exacerbations. I think what's really important is the acknowledgement in the first instance that it's very difficult to differentiate between an exacerbation of ABPA, an acute exacerbation, and other issues that people have going on in their airways. And many of you in the audience will culture organisms like Pseudomonas or Haemophilus influenzae that are bacteria that can make us feel more unwell. And it's very difficult for healthcare professionals and patients alike to differentiate between the two things. And often it's a case of trial and error whether we treat the Aspergillus or we treat the bacteria, and we don't always get it right. I certainly don't. What we do know to diagnose an ABPA exacerbation is that patients need to be symptomatic. That's fairly obvious and straightforward. But we also say that there should be a 50% rise in their total IgE or And I probably put more stock in this part, that patients should have radiological changes. So for example, chest x-rays or CT scans that change when they develop a flare. And this is what the British Thoracic Society say that we should do if patients develop a flare. So we should treat exacerbations as in a first line with prednisolone, so steroids. And that should be at a dose of 0.5 milligram per kilogram of the patient's weight and a maximum dose of 40 milligrams. I think often we overtreat patients. So someone can weigh 60 kilograms and we give them 40 milligrams of treatment. And actually what the patient needed was a 30 milligram tapering dose. And that can lead to a lot of side effects and complications with regards to prednisolone use. And I'm sure people in the audience will have experienced those. That prednisolone dose should wean, and this is a really critical difference between the BTS guidelines and the ISHAM guidelines. The BTS recommendations is that the patients should wean their steroid dose over the course of 2 to 8 weeks, so a kind of maximum treatment of 2 months worth of prednisolone, depending on the patient and the clinical situation. Triazoles, so drugs like itraconazole, voriconazole, posaconazole, should be used as a second line, really. So second to prednisolone, and so if prednisolone should be avoided because patients have side effects to it or have failed to control the symptoms and restore lung function. And again, that is different from the ISHAM guidelines. And I'll show you that in a second. This is the maintenance therapy. So remember I talked about differentiating between an acute exacerbation and what we need to be on maintenance to stop those exacerbations. And people will often come to me in clinic and say, well, Huw, you've taken me off my azole, my itraconazole, so I'm not on any treatment for the fungus. And I say, actually, you are. Your inhalers are part of that treatment regime. They are stopping that excessive, inappropriate white blood cell proliferation and communication. And things like the IgE and the eosinophils that you will be all too familiar with are controlled by your inhalers. And again, I've left that on the screen for people to take photos of. But on the right-hand side, is a really important box that I have enlarged here, and you will see that step 3 and step 4 is when things like long-term azoles start coming in, and increasingly things like monoclonal antibody therapy. So you'll see that in step 4, and that's often my end goal to get people onto that because of the complications and side effects people have with long-term azole therapy. I'll move on to the ISHAM therapy now. So remember, this is the International Society of Human and Animal Mycology. So these are international guidelines as opposed to British-centric ones. I suppose I should just go back and actually say, in order to get patients on to monoclonals, so biologics, patients need to have 3 or more exacerbations per year, or they need to be maintained on long-term steroids. So the treatment from the ISHAM is a little bit more complex. You'll firstly see that patients, if we look on this flow diagram here on the left, it says glucocorticoids or itraconazole. So it's not making a differentiation between the first port of call being steroids and the second port of call being things like itraconazole, like the BTS is. And they choose, you can see in brackets, 4 months worth of therapy for patients. And that's critically different with the 2 to 8 weeks that the BTS recommend of steroids anyway. And that's really important. You'll remember that I said to you that just now that patients, in order to qualify for biologics, need to have 3 or more exacerbations whereby they have prednisolone a year. If we adopt the ISHAM guidelines in the UK, then patients will have when they have steroids, will have them for 4 months. Now, 4 months is a third of a year. So if we adopt those guidelines, really very few, if any, patients will qualify for biologics, because they would have to be on steroids permanently in order to qualify. So I've had a few patients come to me and say, Huw, these guidelines have said that I should be on steroids for 4 months, and you've given them to me for 8 weeks, and this is why I haven't given them for as long. The rest of the things are fairly in keeping, really, but that is the critical difference, really, the length of steroid and azole therapy, and the fact that it doesn't differentiate between a first and second choice. Things like the dosages for steroids are exactly the same. And these are some of the trials that have resulted in these guidelines, and I think these are really, really interesting. And because of the interesting part, I've kept them on, but I hope it doesn't cause confusion. But I'll just talk to you about the various studies, and hopefully with my description of them, they'll be a lot clearer than the slides are. This is the first one that I wanted to show everyone, and this is a trial comparing itraconazole and prednisolone in acute stage allergic ABPA. So acute stage being a flare. So you see, first of all, that the numbers used in the trials are not particularly big. 63 patients ended up getting steroids and 68 patients ended up getting itraconazole. And they were followed up over the period of a year to see how they got on. On the right hand side, I've shown the two groups. So in this table, you see the outcomes, so the primary and the secondary outcomes. This is what the researchers were looking for. And then as you go through, there's the prednisolone and the itraconazole group. At the very, very right is what we call the p-value. So this is when we've done a mathematical calculation, and we look at if the results are significant or not. And the only one that...
So in the meanwhile, look after yourself and be...
Beth, could we just mute that person? Lovely, thank you. So you will see, so the p-value, it's funny, you need it as low as possible for it to be what we call significant and for there to be a real difference in the data. And the only one that we found reached significance needs to be lower than 0.05, was this top one, subjects with a response following 6 weeks of treatment. You can see that 100% of patients had a treatment response in the first 6 weeks being on prednisolone, and 88%, still quite a lot, had a treatment response whilst being on itraconazole. So what we know from this study is actually prednisolone works faster than itraconazole, and that 6 weeks of prednisolone confers a benefit to patients. So again, we don't necessarily need that 4 months. It works after 6 weeks. This is another study that I've included for us to look at. And this study looked at prednisolone alone versus a combination of prednisolone and itraconazole. And a lot of patients come to me on both prednisolone and itraconazole, or some people will say, a lot of healthcare professionals very reasonably ask me, would a combination of pred and itraconazole be helpful for this patient? And this graph here on the right hand side, I hope everyone can see my cursor, is what we call a Kaplan-Meier graph. And it shows on the x-axis the number of follow-up days, and on the y-axis the number of patients that are free from exacerbations. And as you can tell, in both the prednisolone and the prednisolone itraconazole group, they fall over time, and you can see that this graph has roughly the same rate of fall. meaning that there is no advantage of having prednisolone and itraconazole versus prednisolone on its own. Now, this study comes with a bit of a caveat because it is being redone as we speak, because there was some question marks over it. So whilst at the moment the guidelines say there's no advantage of being on a combination, actually that might change in the future when we find that research and that data is freed up to us. And this finally is the study looking at biologics, which as I say, is a big push for me to get as many people on as possible, because it's new technology, and generally speaking, newer technology, there might be a few people who disagree with the statement, but newer technology is better than old, and I want patients to benefit from this new drug as opposed to things like azoles, which do obviously work but have been around for a very, very long time. And I hope, and it'd be really interesting to hear from some of the patients on the call that have gone on to biologics, that their life has got better being on biologics as opposed to being on a lot of azoles. This is the oldest biologic that's in existence. So this is omalizumab or Xolair that some of you may have been on or might still be on. And this is a study that was done in 2023. It's what we call a meta-analysis. So someone has got together and spent a huge amount of time looking at all the different studies and seeing what the effect in that particular study was of omalizumab. And you can see all these names and dates down on the left-hand side of this table, all the different studies. And they've done these plots here, rather confusingly, of swapped axes halfway through. But on the left, you can see that these studies favour omalizumab. And on the right-hand side here, these studies favour omalizumab as well over standard treatment. So you can see the evidence for ABP for biologics in ABPA is really, really there, and is something that we need to embrace, I think. So what do we do in our clinic in the National Aspergillosis Centre? And this is my last slide. I hope I've kept to time reasonably. But what we try and do is I've written here engage brain, and this is a luxury that I have in my clinic because we do in our clinic see patients for about half an hour a time, and that luxury isn't available to every doctor in the NHS. But I try and phenotype the disease as much as possible, so I don't do a one-size-fits-all treatment, and I try and understand whether the patient in front of me has more of an infective type picture, or do they have a Th2 high response? And what I mean by that, if I just go right the way back through my slides, back to this awful picture, which I hope some of you liked, but this Th2 high response, as my cursor's circling this named Th2, is this response where you get high IgE, high eosinophil counts, and this is the response that works with biologics. You can see here there's another one, the Th1, and this is a much more effective response, which is led by our white blood cells called neutrophils. And this generally requires the use of azoles because of a lack of drugs. What often happens in reality is that patients are very, very difficult to phenotype, which is why I've done this little bit of an overlap here in the picture. And some people might have a combination of a productive cough, which we generally think is infective, with lots of kind of nasty green sputum and things like that. But they also might find that cough is worse at night time, and their eosinophils are very, very high, and it's difficult to ascertain whether those patients need to have biologics in the longer term or whether they need to have azoles. And it is a little bit of trial and error, as I'm sure a lot of my patients on the call would testify to. But I think eventually we usually make an improvement to patients' health and well-being. I would hope so anyway.
Have you got a question? We're going to be hearing Marcella's story she recorded for us shortly. Okay.
Thank you so much. Thank you so much, Dr. Ellis. It's a pleasure to be here with all of you. My questions, it is, as you explained, prednisone and axils, it's not necessary doing the both, as I understood. So my questions, it is, and if we are intolerant to prednisone, so in my case, I have the side effects of the both drugs, voriconazole, itraconazole, and prednisone. I have ABPA. So sometimes it's very difficult to find the balance between all of the drugs. So maybe a different case, but what is your idea on me, or your opinion? Thank you so much.
That's a pleasure, Marcella. So what I'll often do with patients is spend a bit of time thinking of, and looking into what the intolerances are. If someone, like yourself, has a big sort of list of the intolerances, what I often find out, and this is definitely the case in the United Kingdom, is that patients are intolerant to prednisolone because either their blood sugars go very, very high, or they feel they don't sleep or something like that. And what you find is that dose of 40 milligrams has just been given, as a matter of course. And actually, the patient in front of you might weigh 60 kilograms, and actually the correct starting dose would have been 30 milligrams. And then a lot of the side effects disappear. So Marcella, I won't ask you to tell us what your weight is on the call, but that might be something that's the case for yourself. What I'll also ask is about the azoles. A lot of people will say to me that they felt very, very sick. And if we're at the last kind of azole to use and we're in trouble there, I'll often think about using something like we call in the UK antiemetic. So these are anti-sickness drugs, and they have side effects obviously as well, and interactions, but those are the sorts of things I look into a little bit.
Thank you so much. Thank you. As I understood, you really want to know which is my weight. Yes. I'm not sure.
You don't need to tell us, Marcella. You don't need to tell us.
No problem. I think it is 64. Yeah.
Okay, fine. Well, you can tell us, because that's much lower than my weight. So 64. I don't know what your healthcare professionals in terms of the doses of prednisolone have used, and I don't know what your side effects to them are, but I would certainly be starting at a dose of 30 milligrams, not 40 milligrams for you, and you might find that some of those are improved. No, 10 milligrams, it's too much. I'm sorry. I'm sorry. What I would say, Marcella, is our body produces a hormone called cortisol, and that acts as our own steroid production, our own body equivalent of prednisolone, and that in a steady state is about 3 milligrams. So it might be that, if 10 milligrams is too much, they start you on, I'm plucking a figure here, 8 milligrams. But actually, if you give 8 milligrams for long enough, that is still higher than the body's own production. And you might find, it won't work as quickly as 40 milligrams or 30, but within a week, it might start having a better effect.
Thank you so much. Thank you. Thank you.
Oh, hi. Hello. Yes, I'm new to the group, and I was diagnosed in and around COVID time, completely unconnected. It's just that it became a thing that I had a chest problem. I've had mixed help from the medical profession, I have to say. I'm based in Cambridge, and you'd think it might be better, but it isn't. But my issue specifically was my allergy specialist put me on hydroconazole as a sort of experiment last summer. It was only a 10-day dosage. I can't remember. I think it was 2 tablets a day, one morning, one evening. And whilst I was on the medication, everything was going fine. I felt absolutely fine. I came off it and I started feeling unwell. Within 4 days, I was rushed to hospital. They thought it was appendix, but it turned out my liver had gone crazy, and my ALT and ALP, which are part of the markers in the liver, had gone to over 1100 or something, ridiculously off the scale. Everyone thought I had hepatitis. I was tested for absolutely everything, and I kept saying, I think the only thing I've taken in the last month is hydroconazole. So finally it was decided that it probably was hydroconazole. Of course, they didn't realise the impact that might have on my life, having been diagnosed with Aspergillosis ABPA. So I'm sort of stuck in a bit of a limbo. Fortunately, I haven't had a massive flare-up since then, but the fear is if I can't take hydroconazoles or any conazoles, I'm in a bit of a position, really. So I just wondered, and I was interested to hear about biogenetics. Was it that might be helpful for me in the future?
Yeah, biologics. So Lucy, there's the Cambridge. I have a lot of interaction with a lot of the Cambridge doctors. I won't ask you to say who you've seen,
I'd be very, very interested, because I'm actually going. Because the first time I saw someone privately, because it was a sort of immediate, it was in COVID, and it was difficult, and it's taken me a long time to get back into the NHS because of that. But I am going to a clinic, but they don't have it's a chest clinic. It's not, we don't seem to have a specialist unless you can point me in the right direction.
Yeah, so there are specialists that exist in Cambridge that they're extremely good. We're spoilt here because, of course, the commissioning for the National Aspergillosis Centre means that I have a clinic where I just see Aspergillus, but there are people who have a mix there. In regards to your question with regards to biologics, I would say don't panic just because you clearly had that issue with itraconazole, which I was sorry to hear. With yourself, I'd be using prednisolone for flares, and I would have a really, really low threshold for, giving you prednisolone. And the reason for that is to get that number of 3, that magic number of 3. And I often find that patients are very, very stoic, and I'll go and they'll say, oh, I'm fine, I'm not doing too badly, blah blah blah, and I'll go and listen to their lungs, and they're clearly wheezing. And often people just get used to that as a baseline, and that's not what the baseline should be. And I'm forever gifting out steroids. People think I have stocks and shares in prednisolone, but to get people onto biologics, and that's not the clinicians being difficult, that's NHS England commissioning that patients need to have 3 courses of prednisolone a year.
Okay, so the fact that I basically seemed that I wouldn't be able to take any of the itraconazoles, any of the conazole family, wouldn't ultimately be a problem.
I wouldn't worry about it. The prednisolone is, in my opinion, and I know that Marcella and others will have had reactions, and I totally appreciate that. For me, I think that the BTS guidelines are correct for that evidence that I presented, that prednisolone should be used first, and azoles in more of a reserve capacity.
Right. Okay. Thank you so much. Thank you.
Pleasure.
And that. I was diagnosed also during COVID with ABPA, and but I haven't had I'm one of that group that doesn't have an other underlying respiratory condition that we heard a lot about at the last year's conference, where one of your speakers talked about that there may be a genetic link. So I'm just wondering about your guidelines seem to sort of imply that on these guidelines that there will always be somehow an underlying respiratory condition, but that there are a small group of people who have it who don't, and wondering why the guidelines maybe aren't taking that into account. I mean, I was never treated with the prednisolone. I'd already stopped seeing symptoms, so I was treated with antifungals alone. And I'm just maintained by a mucus thinner now, and being careful about gardening and that. Sorry, I seem to be rambling.
Not at all, Jan. So I think there's a differentiation, and the reason they mention obstruction in the airways, and I must reiterate, that is not a physical blockage. That's the airways as a whole narrowing, as you might see in things like asthma. We have to differentiate that with something like atopy, which is a combination of allergic type conditions, such as asthma is one of them, but also hay fever and eczema. And a lot of patients with things like hay fever, as we call it, it's not necessarily a reaction to hay. Aspergillus can drive that IgE and give us a lot of symptoms, particularly upper respiratory tract symptoms, and that is undoubtedly a sensitization in part to Aspergillus, but may not be that obstructive phenotype, which very strictly speaking is what ABPA is about.
Well, maybe I don't have hay fever. I did have a collapsed lung, and that's how it became to be diagnosed, and that. So obviously my right lung had filled with mucus plugs, and that. And because of the delay in treatment and things, actually my lung had, after the bronchiectasis, had started to reinflate, and with mucus thinners, the plugs had disappeared, and that. But I've still got a very high IgE, which my consultant keeps being very confused by, and that. But we've agreed, while I'm well and don't show symptoms, there's no point in giving anybody any medications, you know.
Totally agree with that point. I think, Jan, that if you've had a lung collapse, that does sound very like ABPA, and you know,
yeah, they did the tests in Leeds for it. Yeah.
I wouldn't be able to comment further without looking at your case in detail, but that does sound very much like ABPA. Yeah. Have you had lung function done at any point?
Yes. I mean, I was very fortunate during the COVID period that a retired respiratory consultant came out of retirement and saw the non-COVID cases, and that, and like you, he spent time with the patient, finding out about the actual patient, and that. And I think I was lucky in the first place, because the first respiratory consultant had spent time getting a bit of a picture about me as a gardener, and therefore that had rung alarm bells for him. Whereas I would just say that the doctors, the GP just went through the sort of list of the NHS guidelines when you've got a continuous cough, and you just can't, and that, and never ever considered that it could be Aspergillosis, you know. And I'm not quite sure why the NHS don't put that in their guidelines for GPs, that's one thing to consider.
I think it's probably because the guidelines for GPs are an initial look-see, if you like, and then it's at that initial point, if it's still going on, then the patient should see a respiratory specialist. And the reason that those guidelines get put in place, Jan, is so that the patients aren't in the kind of the primary care setting for longer than they should be before going to the secondary. So I think that's why, because the guidelines would like you to be under the care of a specialist in respiratory. Beth, have I got time to make just one more comment about gardening, or are we short of time?
Our next speaker's not for another 10 minutes, so
Oh, okay,
go for it.
fine.
And there's
great,
one more
because
question from the comment that I'll
Lovely,
ask.
great. Well, so perhaps I should have put something in about gardening in the slides, but I thought it might come up in the questions. So in both the BTS and the Isham guidelines, there is a recommendation that that gardeners should avoid things like composts. It's not a please avoid gardening altogether. We never want people to change their lives, but I think it's reasonable to say that about composts. Now, when we make these recommendations, we need an evidence base to make it on. And in the talk, the last slide, I talked about a meta-analysis, and that's the kind of evidence base that is the strongest. Lots and lots of trials have been done, and they've all been considered in due course. There are no studies that have looked at gardening and exposure to Aspergillus causing exacerbations. Those guidelines have been made because of expert consensus by consultants and by doctors. It's something we feel could be important, and therefore we've made it as part of the guidelines. But I think it's imperative, especially for people who might be professional gardeners, that they understand that recommendation has no kind of strong evidence base, no trial basis for it to have been made. What I would absolutely always recommend is that my patients avoid things like composts if they can, and if it's very, very difficult, then to wear a mask when they're using around composts, or indeed in the autumn months when there's a lot of leaves and things on the floor. So I don't. Does that answer the question, Beth, or is it something a bit more specific than that?
Oh, the question, it was a different one. Just on the topics of masks, so Aspergillus spores, they're really, really tiny. So a normal sort of COVID type cloth face mask isn't going to keep them out. We normally recommend FFP3, but if you check when you buy a mask, you'll probably have to go to a DIY store to get one that's got fine enough particles. The comment that we, the question that we,
sorry. Can I just say that was really helpful about the gardening? I do wear a mask and I do avoid compost and things, but that was really reassuring. Thank you.
Pleasure.
Oh, good. The question we had that came up in the Q&A, it was to do with somebody who's been on itraconazole for quite a long time now, and that just had some concerns about long-term use. They've been on 200 milligrams for more than 2 years, but they've been told they look more like a SAFs than ABPA at the moment. And sort of, do you have concerns about a patient staying on that long?
Oh, SAFs is a head scratcher. I think so. The term SAFs kind of came about actually before we changed those guidelines. So it was an acknowledgement that Aspergillus can sensitize people and cause symptoms, but that total IgE number wasn't above 1,000. Now we've changed that IgE number to be below, anything above 500. So it does put a big caveat over the term SAFs, because a lot of those SAFs now will have transformed into ABPA because we've changed the guidelines. The concerns over it was hydrocortisone, was it, Beth? Patient was on. Sorry, you're muted, Beth.
Itraconazole.
It was itraconazole. Okay. So my practice, I really try and not have patients on itraconazole and other azoles for longer than a year. That the studies that have been done were all at 4 to 6 months for an acute exacerbation. I think in an era pre-biologics, when there weren't good alternatives, patients did get put on drugs like itraconazole for longer than a year because we didn't have alternatives. If if I try and take patients off itraconazole and try and replace them with biologics, it can be really tricky. And I would always recommend that someone have a short synacthin test first if they've been on azoles for longer than 6 months, to make sure their adrenal glands are still working and still producing cortisol, because you can put people into adrenal crisis. I'll just clarify, if patients are on itraconazole for longer than 6 months, I do a random cortisol level, and if the cortisol is fine, then I won't do a short synacthin test, but more often than not it's low, and then I will do a short synacthin test. We can do that in Manchester if you're under our service.